prognosis as compared to secondary.
Okay, so Dr. Rajeev, what are the factors that can cause or contribute to pulmonary hypertension?
Actually, the causation of pulmonary hypertension is varied, and depending upon the various causes, the WHO has classified this into 5 groups. Group A, group first, which comprises of the pulmonary artery hypertension, which could be idiopathic, could be heritable, could be drug or toxin induced, could be associated with congenital heart disease, connective tissue disorders, cystosomiasis, portal hypertension. It could be in the responders of the calcium channel blockers, could be associated with the overt pulmonary veno-occlusive diseases or persistent pulmonary hypertension of newborn. It can be also, the group 2 comprises those patients who had pulmonary hypertension due to left heart disease. That is, in patients with heart failure with preserved or reduced ejection fraction, in patients with valvular heart disease. Similarly, the third group, which comprises pulmonary hypertension due to lung causes or lung disorders, or hypoxia, such as obstructive lung diseases, restrictive, or where there's a mixed pattern of diseases also there. It is also seen in those cases where there's a developmental lung disorders. Then the group 4 is those patients who have pulmonary hypertension due to pulmonary artery obstruction. That is chronic pulmonary thromboembolism, or when it is secondary to sarcomas, various other malignancies as well, renal cell carcinoma, germ cell tumors. Similarly, the 5th group, which comprises where the mechanism is either unclear or there's a multifactorial mechanism is there. For example, in cases such as a very rare disorder such as pulmonary Langerhans histiocytosis, glycogen storage diseases, Gaucher's disease. Also in those patients of chronic renal failure with or without dialysis who are having, as Dr. Arunachalam has told regarding this HIV infection. So these are, in these 5 different classes, the causation of this pulmonary hypertension has been grouped, and depending upon that, its management and its approach has been devised.
So, doctor, when we talk, since we did discuss that, young women or middle-aged women have a higher tendency of getting this illness, can we discuss pregnancy, which is obviously, that's the age for, pregnancy. So what are the pregnancy options for patients with PH?
That's most important aspect rather in a childbearing woman who's having pulmonary hypertension. It is important because from the starting days when the mortality was very high in the tune of around 50%, though with the advancement in the medical science, it has reduced to the level of around 10%. But despite it, there are numerous maternal and the fetal issues which basically propel that we should avoid pregnancy. The lady should avoid pregnancy when she is having this pulmonary hypertension. The reason is that she can have increased this refractory hypertension. She can land up into pulmonary hypertensive crisis, volume depletion, preeclampsia, and that can lead to IUGR, prematurity, perinatal mortality. There could be increased mortality in the children, increased risk of congenital heart disease, and increased mortality and morbidity in female, that is the mother. And the reason, because of this is a very, particularly disease, as Dr. Arunachalam and Dr. Rahul and Dr. Rajat has very beautifully elucidated, this is basically a multifactorial. There are numerous causes are there, numerous implications are there, numerous pathogenic mechanisms are there, which act at the level of pulmonary vasculature, which increases the pulmonary vascular resistance, the increase in the pulmonary artery pressure, and that's why there's an affection in the left heart pressure as well. And so there's a decrease in the left ventricular output, leading to, if you, for example, as Dr. Rahul was saying, that when you use the diuretics to just prevent this pulmonary congestion and to relieve edema in these patients, if you do some sort of over-diuresis, there's a volume depletion that patient can have this pulmonary hypertensive crisis. So a lot more complications can occur, and that's why pregnancy is not advisable in these patients who are having pulmonary hypertension. And we should, particularly the baseline risk factors in these ladies are also should be assessed at that time. If some other way, if the pregnancy occurs, then a multidisciplinary approach should be instituted, and where you involve a cardiologist, a gynecologist, intensivist, a pulmonologist at the same time. So as to, you have to ensure, because the most of the complications which occur, they occur during the first week of the postpartum. It can occur during the delivery time. It can occur during any time, rather, because of, and that's why it is very, very important. You have to choose your appropriate drug. For example, the certain drugs are very readily contraindicated in these patients. As Dr. Raul said, this newer drugs such as this gonal cyclase stimulators and various other drugs. And that's why it should be very properly tuned so that both the mother and the baby can be saved. So that's why, since the mortality is very high, so the only thing is to avoid it. And the means that can be used is that it can be very sort of this contraceptions, methods of contraception could be used in form of vasectomy of the male partner, or female sterilization, or long acting this reversible contraceptive methods devices could be used.
But doctor, I'm just going to ask you a rather complex issue. In this particular case, it's not just the girl or her husband. There's a whole community, society, family members.
Yeah.
There are a lot of additional complications like that, aren't there?
Yeah. Because it's not only about the mother. The fetus is also equally important, and that's why, as I told you, there's increased risk of prematurity, there is increased risk of perinatal mortality, there is increased risk of congenital heart disease in these patients are there. The patient that the fetus, the baby who grows, he may have a very complex congenital heart disease at birth. So that's why this is the beginning idea is taken as that you should avoid pregnancy in these patients. All those ladies who are having this pulmonary hypertension should avoid pregnancy. However, if it occurs by some or the other way, then early termination should be done. That is more fine. But if that termination time has passed down, then you have to just fine tune all those things. You have to do it early delivery. You have to plan the whole thing so that the complications can be minimized, because as Dr. Rajat has already told, numerous complications starting from right heart failure, overt right heart failure, LV failure, thromboembolism, anything could be there. So that's why, so as to avoid, because we basically go by the idea prevention is better than cure. That's why pregnancy is avoided in these pulmonary hypertensive patients. And yes, the whole family gets affected. The whole family gets affected.
And that's exactly where sometimes the problem may also lie, because family is involved in this kind of a decision. Well, thank you, Doctor. Dr. Rajat,
Sudden increase in exercise should be avoided, and preferably patients should carry an additional source of oxygen.
When we say that, they need oxygen, also obviously high altitude places will be an absolute no-no for them as well.
Yes, ideally they should avoid such places.
Okay, thank you, Doctor. So, Dr. Rajeev, now, let's talk about what are the new treatment modalities or technological advancements that you can tell us about.
Yeah, newer technological advancements are initially forms of drugs, such as we have got certain drugs, that is selexipag, that is IP receptor antagonist. We have got this gonal cyclase stimulators, that is rosiguat. Apart from all the initial, where it was the whole journey starts back from oral and injectable use of this prostanoids and endothelin receptor antagonist, and phosphodiesterase inhibitors we can't because they are cheap, in form of sildenafil, which is getting more and more commonly used nowadays in our clinical practice. And with the passage of time, as these newer drugs, that is rosiguat, the selexipag, as they are getting more and more cheaper, they are getting more and more use. Apart from this, we all know this is a multifactorial disease, and it has got its implications at different levels. So apart from this, the other modalities, if the patient does not respond to these the conventional pH specific drugs and these other newer drugs, then he is switched over to, that is, balloon atrial septostomy. The purpose is to relieve the pressure, or ultimately to the lung transplantation. But though it is not done in every cases, but that's the final modality, as we do all in all our cardiac diseases. That is the final course of treatment is the heart transplant, from the initial that whatever we do in coronary artery disease patients or heart failure patients. So like this, in the treatment modalities in this pulmonary hypertension, which is very much underdiagnosed nowadays at present, now because of this such sort of initiative which we have taken, at our level also, all cardiologists and all every clinician is trying to promote this, that every dyspnea is not because of lung. Every dyspnea is not because of only lung causes, because people used to think that, okay, I'm having this respiratory problem only in form of COPD or asthma or COPD asthma overlap syndrome. Mind you, rather, if the patient is having an exertional dyspnea, it is because of heart. It's form of heart failure with a growing entity of this heart failure with preserved ejection fraction, which can also lead to pulmonary hypertension, which I told you that it is because of, it is grouped in another group number 2. So, and with the growing knowledge, different other newer drugs are also under trials. Apart from this, now we are using, now various companies have also come with these drugs, Rosiguat and Selexipag, apart from this, ambricetan and bosentan and masentan, and different other combinations also. Because we have seen initially the monotherapy is tried, then the dual therapy is tried, then the triple therapy involving the 3 drugs, or this balloon, atrial septostomy, or final resort is that you go for a lung transplant. So these are the different approaches one can go from a simplified approach by the use of these conventional drug to a specific drugs.
Doctor, thank you.